Good morning and good afternoon, everybody. I'm really honored to be here and share our experience with this. I think this is a really valuable topic. So my name is Michael Weiss. I'm the program coordinator for Humboldt County's Department of Health and Human Services Public Health Branch, and my program is called the North Coast AIDS Project. Okay, there. So this is just a little image of where we're located in Northern California. A lot of people think of Northern California as San Francisco. We're actually 5 hours north of San Francisco. Humboldt County is a rural county between San Francisco and Portland. The federal census classifies Humboldt as frontier. Frontier areas are sparsely populated rural areas, which are isolated from population centers and services and have a population density of 6 or fewer people per square mile. So we're about 3 to 4 hours drive north to south, 2 hours drive west to east, 5 hours north of San Francisco, 7 hours south of Portland, and we have very little public transportation within the county. We have a really unique LGBT community. Humboldt County has a robust community that is attributed to a few reasons. We're the home of Cal Poly Humboldt, which in California, we're the first queer studies program in California that was founded in 2003. So this was a destination location for people in the queer community. 80% of the students currently come from large California cities like San Francisco, LA, San Diego, and Sacramento. We have a local FQHC, which has an HIV clinic, a robust HIV clinic. Again, that's the only one between San Francisco and Portland. It has the only trans care clinic between San Francisco and Portland. This was a community-driven program where the community went to our FQHC and talked to them about the lack of services and asked them to get trained, and they did and started a clinic, which is great. Our FQHC is called Open Door Community Health, and Open Door and Cal Poly are also PrEP app contractors with the state of California, which is the PrEP assistance program in California. We also have the largest cannabis producing region in the United States, and within the cannabis industry here, every year we have worldwide travelers that come to work in the industry, and many of which are LGBT community members. So within our program, prior to 2018, outreach opportunities to the MSM community were very limited in Humboldt. We had a few events on Cal Poly campus, like sexual health fairs, where we would be able to go and do testing. Those were short events, and we might be able to get up to 3 tests done. We also have community events like an annual Pride event, but this is not consistent. And when they do have the Pride event, if we had multiple testers, we could get between 10 and 15 tests done during that day. We also have pop-up queer nights at local bars, which might include drag shows or dance events, and those are other opportunities, but again, they're not consistent. What ignited our social media strategy? Well, let me share that with you. In 2018, we had an HIV syphilis outbreak in Humboldt County. We called this a HIV syphilis syndemic. Prior to the syndemic, the county had an average of 1 to 3 new cases of HIV per year. The syndemic was declared when there was a spike in HIV and syphilis cases. The definition that we used was new confirmed HIV and early syphilis diagnosis, diagnosed after 2015-17, residents of Humboldt County diagnosed in Humboldt County, or epidemiologic link to the confirmed cases, and all persons in Humboldt County living with HIV who are not virally suppressed. So what happened at that time is we had 9 new HIV diagnoses over a period of 1 month. We also had 48 new syphilis cases in that same time frame. 6 of the cases were co-infected with HIV and syphilis. So traditionally in our mobile outreach where we do testing, we use the CDC base goals, which you can see here in this diagram. The image shows our program's regular goals. We had very specific investigation priorities and outreach goals for this endemic. For the investigation, the goal was to identify the identification of infected individuals, identification of the source of the infection, control of the illness transmission, and prevention of illness reoccurrence from the same source. The outreach goals at the time were increase knowledge of transmission, increase awareness of prevention services, and increase access to prevention services. So in doing our strategic development, at the beginning of public health staff meeting, we discussed these topics. Public health team assembled, who was going to be on that team, data, which was the who, what, where, when, how, surveillance data reporting from clients, who were the partners, meeting avenues and risk factors, and surveillance mapping, who was connected to whom. We also looked at partnerships, who else should be consulted, who is already working with these communities, and who can support efforts. And then outreach, what was already being done and where were the gaps. Looking at our partners, both externally and internally, we pulled together quite a large collaboration. Internal partners with public health, which our public health is part of an integrated system of Department of Health and Human Services. So our internal partners included DHHS admin, DHHS communications department, the IT department, and then within public health, we had communicable disease department, public health STI clinic, public health laboratory, and epidemiologists, health education division, and then my program, the North Coast AIDS Project. With our external partners, they included the California Department of Public Health Office of AIDS, the California Department of Public Health STD Control Branch, our local FQHC, remote health clinics such as Hoopa Reservation and in Southern Humboldt, which are extremely rural areas, and then also Cal Poly Student Health. This is an example of our surveillance map that we actually used. We identified 63 partners and potential exposures. The circles on the left-hand side represent a surveillance failure. These were areas where we were unable to get partner contacts due to individuals stating they deleted their hookup apps after their diagnosis, they didn't want to list their partners, or their partners were anonymous. The coding, the yellow are confirmed cases, the green are probable cases, the blue are suspect cases, the gray are potential contacts, the orange are previously diagnosed transmission risk, and the purple are known contacts of the case. So our surveillance characteristics included age 20 to 30, anonymous sex partners, multiple sex partners, recent syphilis infection, sex partners who met through smartphone applications such as Grindr, male, transgender, and gender non-binary, and had male sex partners. So the characteristics of newly infected individuals do not necessarily predict characteristics of future cases, but can help communicate risk to patients reluctant to be tested. The majority of the individuals with new HIV infections and their partners reported meeting sex partners on the dating apps. So our process was hugely collaborative. Internal process with Humboldt County Public Health. We had weekly meetings reviewing line lists from the state, updates on surveillance and outreach efforts. We released health alerts to medical providers, and we worked with admin approach to outreach efforts on social networking. So admin finally approved our outreach on the social networks. Communications department approved all messaging and images that were used on the apps. The IT department purchased iPads and downloaded apps onto them. This was not easy because in our system, we have outside approved list of apps, and these were not part of that. So they had to go through special process to get these apps onto our system. And then program staff increased testing hours and locations. Our collaboration with CDPH, California Department of Public Health, included setting up weekly conference calls. The state sent DIS workers to support surveillance efforts locally and provided support to advertisement on some of the apps in ways that we couldn't do at a local level. And we worked with the Office of AIDS Health Officer on marketing to contact Grindr. We worked with the FQHC to distribute educational materials about local services, and with Cal Poly Student Health to also do the same. But then we also partnered with Cal Poly and created an MOU to allow our mobile outreach van to go onto campus and provide testing and prep services. And then we also partnered with our remote clinics to coordinate on-site testing. These are the social networking apps that we used: Growler, Grindr, Scruff, and Craigslist. Those are the most used apps in Humboldt County at the time. The interesting thing is each app has unique posting rules, so it's not consistent across. For instance, Craigslist, when we started that was not successful. Our ads continuously got flagged and deleted. Scruff profile, with Scruff, the profile pic must be a real person. You can't just have like an advertisement. They also have availability of multiple pics that can be viewed in the profile that are not considered private pics. They had at the time an advertising opportunity called Benevolent Ads. These were free banner ads offered to public health, but this unfortunately is no longer available. When we had the banner ads, we had full control over geographic placement and also full access to data, but that no longer exists. With Grindr, there's no regional advertisement available. When we tried to advertise with Grindr, they just did Northern California, which included San Francisco and the whole, and so it wasn't reasonable for us. With Grindr, you have very limited character count when you're building your profile, so that you have to be really strategic on what you say and how you say it. Grindr can also have multiple pics viewable, but they do not allow phone numbers on Grindr. They get flagged, so we're not able to put like the phone number for our public health. With Growler, it was more like Scruff and had easier use for the profile setup. Here's an example of some of the images we used. So the one on the left, that was a Scruff ad. So was the one on the far right, because those had real people in them. They didn't have to have the face, but it had a real person. The one in the middle, we could not use on Scruff. It kept getting flagged and deleted. That we were able to use that on Grindr. Grindr allows you to do images, so that made it easy. But our outreach was passive only. For instance, we never initiated a conversation. We just set up our profiles explaining who we were, explaining that we were an outreach worker with public health and that we were here to answer questions around sexual health and testing services. With the outreach, though, it's important to know that everything can be a conversation starter. So often somebody would send us a woof or a tap, which in the apps can be known as like somebody reaching out and saying, I like you, or I think you're cute. But what we would do with those is we would respond with the person and say, thank you very much. and then explain who we are, why we're there, and if they had any questions. And often people did have questions. So any kind of contact, we would take advantage of that opportunity. Here's an example of our profile messages. The one on the left is Grindr and the one on the right is Scruff. You can see how on the Scruff side, there is much more space to put, there's no character limit. So you can fill out a lot more details about what you do, but at the bare minimum, excuse me, in the display name, the headline will show on the picture in the thumbnail, will say something like, ask me, or get tested, or something that tries to catch somebody's attention. And then when they click into the profile, there's a little more detail. So what we would say is, I'm a Humboldt County public health outreach worker. I'm here to answer questions about sexual health, PrEP, HIV prevention. I can also help connect you to local resources and free HIV testing. I'm available from Monday through Friday, 10 to 3. That was really important to put the hours that were actually available to respond in live time so that people aren't sending messages and wondering why we're not responding. In the profile demographics, we kept those blank. And in areas where it said, what are you looking for? We would say chats. Here's an example of the Scruff banner ads that were available at the time. The banner ads would pop up multiple times within an hour, depending on how many other banner ads were available. So in the very top, the red and the green, those were examples of the banner ads where we would just say, Humboldt is seeing rise in HIV cases, or syphilis is on the rise in Humboldt. And then when they clicked on it, they would get the gray ad that would pop up that would give a little more details about what's going on. And if they wanted more information, they would click that button, which could take them to an outside website like the public health website or a testing website. Unfortunately, Scruff no longer offers these, and they only offer purchase ads. So who was responsible for this? It was everybody. We had everybody in our program sharing, monitoring the online communications. We did outreach workers, testers, our PrEP navigator, case manager, and myself, the coordinator. It was easy to hand it off to another person if somebody got occupied or if somebody was off. So that made it very easy to be consistent with communication. We would not identify ourselves other than I'm a public health outreach worker. So sometimes people would ask who we are, or are we a guy or a girl, and we wouldn't really answer those. We would just say, hey, there's many of us working this. We are a public health outreach worker and we're here to answer questions. So our outcomes, this was interesting. We showed an increase in accessibility of services, acceptability of services, and availability of services. So we had online outreach to extreme remote rural areas and cannabis farms, online outreach to underserved and isolated communities such as the Hupa tribe, Southern Humboldt, which all included an increase in access to Native American, transgender, and MSM people who normally wouldn't come into public health to get services. We had our FQHC distributing educational material about services throughout all of their clinics, but also in their support groups. We had public health provided presentations to transgender support group and LGBT and youth groups throughout the county. Excuse me. Accessibility of services. We had an increased awareness of STI and HIV and PrEP testing services, improved understanding of risk, and availability of services. We expanded mobile testing to isolated communities. We improved coordination with other providers such as the Kamau Medical Center in Hupa and the Redwoods Rural Health Clinic in Garberville, and these relationships are still ongoing. Here's an example of the data we got from the Scruff Benevolent ads. These are impressions. An impression is counted each time your ad is shown on the site, each person's page. And then we also got this. This is click data. It shows how many times a person clicked in the ad in a particular time. So the data at the time was really great. I wish we still had this available to us. And here's actual real conversations that we had with people. So you can take a look at those, but some of the things that we tracked were the date of the conversation, which app was used, the primary topic and secondary topic, and then an action item outcome. So somebody's primary topic might be HIV in general, and the secondary topic might be testing. So examples of conversations we had, 30% of our conversations were about PrEP, 25% were about HIV testing, 25% were actually compliments. For example, people saying, thanks for being here. And then we had other topics, including HIV stigma, STI testing, treatment options, insurance cost, side effects, and risk assessment. Some of the action outcomes within our department, and I say this within our department because we were unaware of outcomes of people who we did direct referrals to a clinic or another resource. Those weren't tracked, but the ones that we were able to track to the end was 13% got linked to testing at public health, 15% got linked to public health PrEP navigation. All contacts involved some sort of information education, but 30% were education information only without a linkage. Example, risk assessment or stigma discussion. We also made other referrals, including mental health services and referrals to insurance. So I'll open it up to questions, see if anybody has any questions about our process and experience.
Thank you so much, Michael. Great presentation. Folks, if you can give Michael a virtual round of applause with your Zoom reactions, that would be great. We do have some questions in a chat that I'll share with you. It was as you were presenting, you may have covered this already. So are these apps, are these the main apps? Are there others? That was a question that was posed.
Okay, there are many, many apps. Those were the main apps that were used in our area, and I think this is really important to know. Communicating with your local community to see what apps are popular, what people are using. So in our area, those three were like the biggest, most used.
We have another question here. Can you add websites to the profile? Love the pictures of shirts with info.
Yes, so most of the apps we were able to add websites. Grindr was a little more limited. I don't believe we were able to add a website in there, but with Scruff and Growler, we were able to add websites and phone numbers.
Great. And then there is a link, a resource that Greg put in the chat. Here are 20 apps. He linked to queerintheworld.com/gay-hookups-apps. As Michael said, they have geographic preferences. And then Greg put another link in there, datingmentor.org/gay-hookups-apps. So thanks, Greg, for looking out in the chat there. We have another question. Were you able to track how many clicks you got from the ads?
Yes, only in the Scruff, excuse me, only in the Scruff data. We were able to log in at any time in the Benevolent ads and pull up the data, and we could see if we did like a push, you know, over a weekend, we could see if the clicks were higher or lower.
Awesome. And then we have another question. How did you measure acceptability?
It was based on the conversations we were having and how many people access services and shared the information about it. So we had a lot of people that the conversation started out with them having very little information and maybe a lot of stigma. And then through those conversations, because we tracked the whole conversations and screenshotted a lot of them, we were able to see, you know, based on the outcomes, who had a change of attitude or who accessed services after the fact.
And then we have some love for you in the comments. This is incredible. Thank you for sharing. Another question here, can you say more about how you track the folks who got linked to care from the apps?
So, like I said, we were only able to track the ones that we provided services within public health. So we do HIV, Hep C, STI testing, as well as linkages to PrEP, insurances, and then other services within our own DHHS system. So any of those we were able to keep track of. Anything like when somebody wanted a direct referral to an outside agency, we weren't able to track those. And there were a lot of those.
Would you recommend using multiple dating apps for outreach? We currently use Grindr. Is it important to expand the reach?
I do recommend using multiple dating apps. And part of that is different demographics of people use the different apps. So in our area, the younger demographic at Cal Poly tend to use Grindr more, and the older demographic tended to use Scruff more.
Let me see, do you suggest one main account or many staff have individual accounts? So I guess you're saying, do you suggest as one account or having multiple staff members have different accounts?
We used, one main account I think was valuable because if everybody had their own sign-in, they would show up as different profiles. And if you want to track the conversations and keep them in record, we had everybody logging into the same account, depending on, you know, who was using it. So we all had the same passcode and sign on.
Did you experience being blocked by folks who were not happy with your organization on the apps?
Yeah, we did. We sometimes we got reported, sometimes we got blocked. But I was really shocked at how many people said, thank you for being here. We're really happy you're doing this work. We got way more compliments than we ever got blocked.
How do you know which apps are most used in your area?
You need to engage with the community that's using them. So, you know, we talked to support groups. We went on the apps ourselves and we're looking at the populations that were there, logged into a lot of apps that we didn't end up using and seeing how many are in your local area. We talked to local queer service organizations and just got feedback from the community.
Awesome. And how do you include people who may not perceive the risk for HIV? Example, heterosexual men and women.
So we actually have a lot of people identified on the apps currently that are looking for, that are not looking for necessarily MSM contact. That surprised me as well. But that said, we did some public health advertising through our media and through the clinics to try and reach other demographics that were not on the apps. So through the STI clinic and through the other health clinics.
And then I think this is a comment/question. Also, I'm assuming any part of a social media outreach plan is also acknowledging the social media campaign limitations. Did you use your in-person outreach, which you spoke about in the beginning, to fill that technology gap?
Yeah, we expanded our mobile outreach efforts into a variety of locations and working with the other clinics, finding out where people are meeting and trying to fill some of that gap. We also did some, I forgot to mention, we did some outreach to some local groups that have sex positive events that aren't necessarily MSM specific, but we were able to engage with them and also get the information out.
And then the last question so far, can you please share the logistics of using social media apps approved through an academic research institution? I would love to implement this at our clinic.
Wait, can you repeat the question?
Yeah, sure. So it says, can you please share the logistics of using social media apps that are approved through an academic research institution? They would love to implement this at their clinic. So any apps that has been approved through an academic research institution.
So we're public health and we're not an academic research institution. But I can tell you that we had to go through thorough process with our admin, sharing the community need and usage patterns, and get approval from our internal media department and our internal IT department to get all of that done. Thinking about possibly Cal Poly Humboldt, they're not using apps right now. They are mostly doing just groundwork with the people in their dormitories, in their clubs, their social clubs, at their events. So I think we're more having access to the students through the apps because they're not using the apps.
And we got our final two questions, but just before we go, do take them and go to break, for any other questions, Michael, will you still be hanging out with us to address them in the chat?
Absolutely. And
okay.
My contact information is also on the screen. So
great.
Feel free to reach out to me even after this presentation.
Great. So we have our last two questions. So, so would you recommend not doing this on more straight focused apps like Tinder and Bumble?
I wouldn't say that. I mean, it depends on who your target population is and what, who you're trying to reach. We haven't used those apps, but we have thought about it. They're much more limited. I know, at least I'm not familiar with how Bumble works, its interface, but with Tinder's interface, you can't send pictures to each other. You can have a few profile pictures, and then you also have limited information. So we've thought about that, and it needs to be a further discussion with our admin.
And then the last question, were you able to see any racial/ethnic differences in engagement or preference for certain apps between groups?
We saw the demographics within people's profiles, but we weren't able to see we didn't notice a difference between Scruff and Grinder. It was mostly an age demographic difference. We had a variety of people from different demographics on each app, but the biggest thing that stood out was age demographics.